Welcome to the Low-Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low-Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Welcome to the Low Carb Empty podcast. My partner in crime, Dr. Brian Lenskis, will be joining me, Dr. Tro Kalasian, to interview somebody I followed on social media for a bit. Quite an interesting story, somebody I'm fascinated by, somebody I want to learn from. Dr. Ryan Cooley is joining us, and he's on social media. He's sort of a lurker, but I've been following him, so I reached out and said, hey, can we get you on? A little bit about him. He's a physician. He did his internal medicine residency training at the University of Minnesota. He did his cardiology fellowship at the University of Iowa. He did his EP, his electrophysiology fellowship in Milwaukee, and he practiced there for 2 decades, and he is now in Utah. And he has a bit of his own sort of reasons for being interested in both lifestyle and metabolic health. And we'd love to sort of explore all of it, metabolic health and electrophysiology. If you don't know what electrophysiology is, if traditional cardiology is plumbing, electrophysiology is the wiring. Hopefully, I'm not oversimplifying it, but it has to do with the electrical conductivity of the heart. So we're happy to have an EP expert here. And I think, my partner in crime, Dr. Brian Lenskis, is now available and joining us.
So Doc, welcome. Glad to have you.
Thanks, guys. Appreciate the opportunity, and should be a fun hour or so. Tro and Brian, I hope you guys don't mind I call you by your first name, and please call me by Ryan. That's totally cool. And Tro, you're right.
Yeah.
I'm an electrician of the heart, but really everything is all interconnected, right?
Yeah, absolutely.
The heart's all interconnected, and the heart's connected to the gut, to the brain, to everything else. So this is a really important topic. Well, I think what I'll do, and you guys just please interject at any time because I have a tendency to ramble. But I think maybe the easiest way to approach this is going forward, or starting off in the present day and then going backwards. And I love talking about my story these days. And you're right, Tro, on social media, I'm kind of a lurker, trying to increase my presence and exposure there. Recently launched a podcast myself with Brett Smith, and unfortunately, both of us had some issues recently, so it's kind of been on a pause. But anyway, in November of 24, I was officially diagnosed with prostate cancer, and it was after a biopsy, and it's kind of an interesting story all in and of itself because my PSA, I'm someone that saw my internist every year, and my PSA went from 1.7 to 3, which wasn't a huge jump, and my primary doc even wasn't that concerned about it. But I went ahead and saw a urologist and had a repeat, and a month later it was 3.4. And so I had an MRI, and that was suspicious for cancer. Biopsy confirmed it. And ended up, after multiple consultations with a lot of different people, and doing a pretty good deep dive myself, I ended up taking an integrative approach. I had a radical prostatectomy just 2 months ago, recovering great, but I also really dove into what cancer is, and I was very intrigued by Thomas Seyfried's work. He's a Boston College researcher, and has kind of been instrumental in the notion of metabolic disease as a root cause for cancer. And so I started implementing some integrative of therapies for cancer as well. So your listeners may not be very familiar with the metabolic theory of cancer, but it surrounds mitochondrial dysfunction and this switch from oxidative phosphorylation to fermentation of fuels to help cancer cells grow and survive and even metastasize. And so these two fuels are glucose and glutamine. And so he has devised a press pulse protocol where the therapy involves pressing which is basically a continuous full court press with a ketogenic diet to limit glucose to cancer, striving for a very low glucose ketone index. So in other words, eat in a way that lowers basal glucose and also eat in a way that raises ketones. So that's obviously the ketogenic approach. And there's some nuance to it, which we don't have to go into great detail about. But the issue with glutamine is that you can't really inhibit glutamine forever because it's an amino acid. And so he's pulsing glutamine inhibitors into the program. And then thirdly, the whole protocol involves hyperbaric oxygen, which is putting an oxidative stress on the cancer. And so I started to do that. The glutamine inhibitor, I think, was the most challenging part of it because what he's using is something called DON, which is an acronym for this deoxynucleotide type thing. And it's really expensive to get. So I did some research on other ways to inhibit glutamine, and I came up with a strategy of using berberine and ECGC through Japanese sencha tea. I'd been on a ketogenic diet because of the metabolic disease that I acquired and my heart issues for the last 6 years. So that wasn't something too new to me, although I had to tweak it to try to achieve a low GKI, glucose ketone index. And then my investigation in this led to some other interesting aspects in that what may be something that is underlying the ketogenic diet is something called deuterium depletion. Deuterium is a heavy hydrogen, and so we make our metabolic water is essentially deuterium depleted. So when we are respiring and oxidizing fuels in the mitochondria, we're producing water, and that water has different levels of deuterium. And interestingly, the ketogenic diet and fats, so ketones and fats, when they're oxidized, they produce less deuterium water. And so, most people, when you're on a standard American diet and you're drinking sort of just normal water sources, you're going to run a deuterium level in your body of about 150 to 155 parts per million. If you just did normal water intake and had a ketogenic diet, you're probably going to be a little bit lower than that. And there's a lot of good science about deuterium levels and the relationship with certain chronic diseases. That, in other words, the higher your deuterium level, the more at risk you are for chronic diseases. And so there's some good science that indicates that you really want to try to strive for deuterium levels, at least less than 140, maybe even less than 130. So I actually did a deuterium level just on a ketogenic diet, and mine was 137. So I was able to lower my deuterium level in my body just by eating in a ketogenic lifestyle. Super interesting, which means that I'm oxidizing fats and ketones, and I'm producing less deuterium in my body. The other thing that was of interest is a lot of these things are also associated with molecular hydrogen. So what they did and what they were doing with patients who were doing the protocol is that they noticed that the DON treatment, the glutamine inhibitor, was resulting in some gastric distress. And so they were giving people psyllium and inulin and all kinds of things that will actually increase molecular hydrogen production in the gut. So the gut microbiome is the only part of our bodies that produce molecular hydrogen. So I took this knowledge and I ran with it, and I started hydrogenating my water with a hydrogen generator and getting my deuterium depletion down even lower by drinking deuterium depleted water. Because hydrogen is the ultimate antioxidant. It's an incredibly small molecule. It penetrates everywhere in the body to help with the antioxidant systems. And we all know that cardiovascular disease is associated with high levels of reactive oxygen species and free radicals and oxidative stress. But I don't want to get too in the weeds with that. But I think it's important because what it really caused me to realize is that I had an underlying cellular dysfunction. I had mitochondrial dysfunction. And I don't really believe that I have ongoing mitochondrial dysfunction, but as part of that disease, and then as part of cardiovascular disease, which I developed. I believe that kind of links everything together. That I had this mitochondrial dysfunction, which is complicated subject, but it's basically cellular dysfunction. My mitochondria was probably not working very well for maybe 20 to 30 years. And I think all lifestyle driven and many aspects of our lifestyle. It can be food, it can be sleep issues, it can be circadian rhythm disruption through light issues, stress, what have you, all those things. I think mitochondrial dysfunction probably is just the ultimate manifestation of modernism, right? All these things that are problematic in our modern world contributes to mitochondrial dysfunction. Then at the age of 52, so 7 years ago, I suffered a heart attack, and that was my first, real clinical serious manifestation of heart disease. And it was at that time that I learned a great deal about myself, about the lifestyle implications and factors that go into atherosclerosis development. I was lucky and fortunate that got in and got treatment and didn't suffer, a significant amount of damage. But what it led to was a diagnosis of insulin resistance. And it took a lipidologist outside of conventional medicine to make that diagnosis. It was kind of interesting, first meeting. She looked at me, she looked at all my data, and the first words out of her mouth was, "You're insulin resistant." And this is something that I talk about a lot when I meet patients, is that if you've got heart disease, it's just simply a manifestation of insulin resistance until proven otherwise. And in most cases, if you look, you find it. I had to have a traditional Kraft test to diagnose it. At that point in time, I was on a vegan diet for probably about 6 months, had lost some weight. I peaked at about 185 pounds, whereas my high school, college fighting weight was 150. And I had dropped down to about 165, so I'd already lost about 20 pounds. Came in as a vegan, and she did a Kraft test, and I flunked it. Floridly abnormal. Had a baseline fasting insulin of 15, and my 4-hour glucose and insulin testing was floridly abnormal. When you kind of look back at my history, I've got a lot of data which derives from the fact that my family history is pretty ominous. I've had coronary disease in every male Cooley dating back to the 1400s and the potato famine in Ireland. My father died at age 58, had a heart attack at age 35. His father died at age 46, and it just goes on and on and on. And so starting at about age 30, I started getting lipid panels and started seeing a cardiologist. And my lipid panels always showed the same thing, which is what my father showed. It was my LDL was relatively unremarkable. In fact, I've never had an LDL-C above 100. And
say that again.
What's that?
Say that again.
I have never had an LDL-C above 100.
So I'm guessing your ApoB has probably never been above, what one?
Well,
one.
The interesting thing is my profile was pretty typical in retrospect of metabolic dyslipidemia. In other words, I always had a low HDL in the low 30s, and my triglyceride was always about 140 to 150. And the response I got from what's that?
What was your weight?
185.
Yeah, I would kind of hovered around. I tended to kind of fluctuate a lot because it really depended on how active I was. I'm someone who's exercised my entire life. In fact, I was a college athlete.
You're like you were a tennis player, marathoner, right?
College athlete, big time cyclist. We used to race and cycling but the exact amount kind of would vary. And so sometimes I'd get a little thinner when I was in heavy training mode. But I was kind of chunky, 170 to 185.
Hold on. So your LDL was basically never above 100.
Yeah.
Okay. Well, I know the answer. You were inhaling cadmium while you were doing cocaine as you were sleepless, right? That must be it, right?
Yeah. No, I mean,
You
look,
didn't do that either?
I exercised, I didn't smoke, I didn't drink. I did not have hypertension. I did not have
the cocaine, Brian. Did you
Yeah.
notice that?
And
He denied the
how
cocaine. He didn't
how
deny the cocaine.
I was a clean guy who exercised, was a little bit overweight. I I I adhered to the dietary dogma of cardiology in the day, which was avoid saturated fat and avoid
Hold on.
cholesterol, but I ate sugar.
I need a pause right here.
Yeah.
Can you tell us about your family? Because this is unusual, right? Like this is a bit, it's not, unfortunately, it's not unusual. Me and Brian see this all the time, and I'm sure
Yeah.
you've seen it all the time. What is there some familial component, genetic component? You mentioned your father. I mean, what about?
Yeah, there is. So I had my genetic testing done and I have an LP little a gene and I run a moderate LP little a level of 131. That's the highest I saw it on
Animal or sorry, I'm gonna
it's
geek out on you here.
131 milligrams per deciliter. Milligram per deciliter.
Yeah.
And that is sort of moderately high. And that was in, again, a standard American diet, trying to keep saturated fat and cholesterol reduced in the diet. And that was a little bit heavy, right? So this is what's super interesting. And I do have the gene mutation. I also have a gene mutation involving lipoproteinemia. I think it's FH type 3, which basically means that I am vulnerable to VLDL not being cleared. So in that setting, metabolic dysfunction, insulin resistance would be an additive problem because that's a problem of increased remnants and triglyceride-rich lipoproteins. And so you're stacking one problem on another there, but I didn't know it at the time. And then I have two obesity genes. I have an endothelial dysfunction gene abnormality.
Are you homozygous for the obesity genes or the sorry,
heterozygous?
We're geeking out. Okay.
Yeah.
So for the listener, we're talking about, genes. LPA, maybe we can just give a little clarity. The LPA is a genetically associated, cholesterol that's minimally but somewhat affected by lifestyle. And some of the endothelial dysfunction, we're talking about the viability of the artery as a tissue. And the obesity genes typically are associated with not being full. And some of them are directing more fuel to fat, but most of them are not being full.
Right. So I think I was trying to pull up a slide because I have it on us. Oh, here it is. I've got FTO, which is homozygous, and I've got MC4R, which is heterozygous, and both of those are obesity genes.
Yeah. So the FTO is a thrifty gene. That actually John Speakman, who just published a study, was the guy who pretty found that one out. And the MC4R You'd benefit from sunlight. Hopefully, you're getting some good sunlight now.
I
You
try.
know,
Yes.
it's a hypothalamic. So what was the endothelial dysfunction genes?
That one
Sorry, we're all
was
geeking out, and all the listeners are like, "What are they talking about?"
Yeah, and I'm curious
yeah.
about like homocysteine and MTHFR deficiency or anything like that.
No, I don't have any of those. The
All right.
endothelial dysfunction gene is it's a kind of a long, it's CDKN2B dash eight.
CDKN2B, is that homozygous?
It's homozygous.
So you are susceptible to tobacco, hyperglycemic excursions, and contaminants, microplastics. A lot of times, yeah, that's interesting. Vitamin C is your ally, you know.
Yeah, yeah.
Uh, that's very interesting. So this was all at an early age, right? When did this all happen?
Well, I was 52 when I had the heart attack. And starting at age 30 is when I went on statin on the advice of the cardiologist.
You were on a
Um,
statin?
I had been on a statin for 22 years. And
And
Twenty.
how long were you vegan? How long were you vegan before this?
only 6 months. So when I had the heart attack, I transitioned to vegan, Esselstyn style, and I did that for 6 months before I saw a new lipidologist. And so I was tested as a vegan for a pretty good amount of time. And so on statin, my LDL-C ran 30 to 40 for
Oh my
20
God.
years. My ApoB, when we could finally test it, was 40. And I had
Brian, Brian, I'm fuming. Like my anger right now is through the roof. Ryan, how are you not like seething in anger right now?
oh, I,
Because
I, yeah, I had to get over that. I had to put it aside and
so I just want to summarize this for the listener because they may not have put this all together, right? And then I want to make it super clear. Dr. Ryan Cooley is a cardiologist. He's a premier physician who devoted his life to helping people with heart disease. And like me and Brian, I devoted my life to helping people with metabolic disease. I found myself at 350 pounds with end stage disease. And you found yourself with end stage heart disease doing what you were told. He was on the statin, his LDL was managed, right?
30. It
And
was overmanaged, 30 or
he was
40, Tro.
and he developed the thing that he committed his life to prevent and to heal and to help. I cannot imagine a world when you start to wake up that you're not just embroiled with rage. Like I have such intense rage, and I'm thinking from your perspective, I would flip out. You went through even more training. You went through even more, you did 4 or 5 extra years of training in this system. When people look at the radical changes happening right now in government and healthcare, they're scared and they don't understand the sentiment of, I don't know your politics, but I know right now, that change is needed.
yeah.
You know, so I have know nothing about your politics, but I know, like me, you're so angry that the status quo is unacceptable. I want to hear that. I want to hear how you process all this, you know.
Well, I went through a pretty dark period because I was stricken with anger and like I said, I thought I was doing everything right. I was getting a yearly assessment, following my lipids all the time. I was so invested in my own career in electrophysiology, I didn't really take the time to continue to educate myself about atherosclerotic disease and what the risk factors really are. And I had no clue about insulin resistance, or over fatness and obesity and the issue of ectopic adipose tissue and all of that. And I had to, in order to move on and heal myself, not just from my heart disease and now my cancer, I had to let all of that go. And I had to just focus on educating myself so that I can educate the patients that I take care of, that trust their care to me. So every interaction is with that in mind. And I'm actually lucky to be in a system now that models, giving us time to spend with patients. They cap us at 16 patients a day. And that's phenomenal. So I'm not RVU based, I'm not productivity based, and it's a great system to be in because it's just unusual because I can now spend the time. I can apply what everything is that's great about our modern centralized medicine, but I can also add in other layers of things that I think are really going to move the needle. I had stress tests every year. In fact, I had an echo stress test 1 month before my heart attack. So these are things, again, low fat diet, low cholesterol diet. What I never,
What
no
about a
one ever,
calcium score? Did you ever have a
that's,
calcium score?
that's one of my probably biggest regrets is that I never did that. And I was always worried about just radiation, really. I was worried because my job was associated with radiation and exposure, and I just didn't want to, it was probably an over concern. But yeah, it was and at that time, the cardiologists still they were not advocating CACs much. My cardiologist, and I saw a couple, to be honest with you, they never advocated for it. I think if they would have pushed it, I probably would have done it. That's my biggest regret. And now since my heart attack, I've had seven scans,
So
right?
can you talk
But
about
that's after being on a statin for 30 years plus years, right?
Can
Yeah.
you talk
So
about your disease? Was it sorry, I'm going to geek out here because we're all doctors. Three out of the three vessels, where was the disease on that initial,
I
52 years old, young?
my heart attack was in the distal right coronary, and I had collaterals. So I think that helped, and I'm assuming my collaterals were probably from a lot of exercise and sort of building up a plaque there. And one day when I was doing a resistance workout, I got chest pain, and it kind of waxed and waned, and it kind of stopped. And so I ended up going to bed, and I woke up in the middle of the night with crushing chest pain, came in, and I was having an inferior STEMI. Um, and I got a stent, did well. Um, and I had a little bit of 30-40% disease in my circumflex. My LAD was pretty clean. Um, there was one plaque in my mid LAD that was about 30%. On IVUS was pretty calcified. I was on a pretty low dose of Crestor at that time, and so post heart attack they smashed me with statins, of course, which is high dose, max dose Lipitor. So I was on 80 milligrams of Lipitor. My CAC was 400. They basically subtracted out this. What they can do is subtract out the stent area. So they look at all sort of the CAC and the non-stented area, and it was 400. And then I repeated it a year later on high dose statin, and it was 700. Okay.
That makes sense. That makes
Yeah.
sense. You're laying down calcification on the plaques.
Yeah. Yeah.
You know,
And now I've had 5 additional scans, and finally year 2, so the third CAC, year 2 on a well-formulated ketogenic diet, which put my insulin resistance into remission with a fasting insulin of 1. My HDL went from 30s to 70s. My triglyceride's about 50. My ApoB and LDL really didn't budge at all. They just stayed where they're at. And and my LDL right now is actually 70, and I stopped the statin because I was getting tendinopathy, and I really felt that the statin contributed to my insulin resistance. Yes, I was a little overly fat, but not a lot. And I felt like it was contributing, and I just stopped it. So off statin, my LDL is about 70, my ApoB is about 50. And my inflammatory markers are all great. And so now my last 5 scans have been completely stable, no progression whatsoever.
Did you add any supplements in like vitamin D3 and K2 and all those kind of things?
Yeah, yeah, I definitely
Nice.
I run my vitamin D about 80. And I do take supplement for that. And I try to get sunlight as much as possible. I do red light therapy as well. Um, and I take vitamin C now. I wasn't before. I do take vitamin K, but vitamin C is part of my cancer regimen. So I did a liquid biopsy for my cancer, which is by a company called RGCC, and I had my blood sent to Greece, and they analyzed my blood for circulating tumor cells specific to prostate, and so I've got a few cancer cells per milliliter, and there's a target that we want to reach to sort of increase the likelihood of remission because I've got positive margins on my surgical pathology, which means I do have about a 50% recurrence risk. And so it's amazing. What they did is they can do this. So they detect the cells. There's about 3 per milliliter, and then they do phenotypic and stem cell markers for prognostic implications. And then they can also test sensitivities. And so I've got this whole planned out month to month. It changes based on sensitivities of natural substances that are categorized into 3 bins. One is class 1 cytotoxic, one is class 2 immunomodulatory, and class 3 is PK inhibitors. And vitamin C is something that my cancer is very sensitive to. So I'm on a pretty moderately high dose of oral vitamin C, among a bunch of other stuff. So it's another sort of cancer treatment. The hydrogen is something I'm super interested in because again, there's actually scientific data on molecular hydrogen treatment for atherosclerotic disease. And so that's something that's pretty intriguing to me. I did have one interesting setback in July. In this last July, actually right before I got diagnosed with cancer, I was out on a bike ride and I was going really hard and it was hot. It was like 98 degrees out here. And I had been completely stable, exercising, with no issues at all for 5, 6 years after the original heart attack. And all of a sudden I started getting chest pain. And I stupidly kind of continued the ride because it was just sort of mild and it would kind of come and go. And I was like, what the hell is this? And I got home. I said, well, maybe it'll go away if I rest. And it didn't. So I went in. My EKG was normal. My troponin was normal, but they were obviously all worried about it. And it was still kind of hanging around a little bit in the ED. So I ended up getting cathed and they IVISed my LAD. And I have my before and after angiogram. So it's super interesting to compare that place, that LAD, mid LAD, where I had that 30% calcified plaque, was super calcified on the most recent angiogram, and there was a flap. There was a little calcified flap just flapping in the breeze there, and he thinks I just sort of sheer stress ruptured it. But it was so old and calcified that there probably wasn't a lot of coagulability concern with it, not a lot of coagulation factors in there or early angry cells in that debris. And so it didn't rupture. It didn't thrombose, if you will. I mean, it ruptured obviously, but the cardiologist was pretty convinced based on the IVIS looking of it that it was just a sheer stress rupture. So I had another stent placed, but again, I've been fine since then.
Tro, we're gonna have to change this into a 4-hour podcast, I'm pretty sure. Were you like a type A driven guy?
Yeah, I would say for sure. Yeah,
Okay.
it definitely was. I was working a lot of hours. I was in that, in that mold of, cardiologists need to, work constantly and, I was in a model again, it was sort of productivity too, which wasn't a good thing for me, but and it was a big cardiology group that was very driven. And so I came through an EP program where they started ablation in Milwaukee, in the nation. They started it in Milwaukee, and they would do ablations on Saturdays and Sundays, and ablations would take 24 hours. And so I came in just short of that, or just after that. And so, these were guys. At that time, it was all guys. There weren't any females in electrophysiology, but these were guys that were working 7 days a week, all day long. And yeah, that was just the mold that you were in.
Besides the stress, and when you were working out, were you like a fanatical workout? Like you'd run long distances and really push it on your exercise?
Yeah, I think that was a contributor as well. I was a tennis player in college, and then I developed a little bit of a knee issue, so I transitioned actually to, high endurance that was friendlier to the knee, and that's why I transitioned to cycling. So I was a road cyclist. We used to go on 4 or 5 hour, 6 hour rides on weekends, and then I started racing mountain bikes. And so yeah, I was pretty hardcore endurance. Haven't done that now for probably about 10 years, but I was leading up to that.
Yeah, because all these things are so interesting, and the big question I have during all this, you're a guy, you have a heart attack at a young age, you go vegetarian or vegan, and then all of a sudden you come off a statin, you're going on a high fat diet for the cancer, and your cardiology friends must have been looking at you like, what is wrong with you?
Yes, I get a lot of that. And then I show them my markers, and then they go, "Oh, interesting," but they still don't really get it. And one of the biggest problems is that all I had to do, or someone in the cardiology field that I was, working with, would have had to say is, "Hey, maybe your HDL isn't genetic," because that's what they said. They looked at my father, his father, and they said, "You just have a genetic problem." And the only thing you can do is try to live a clean life and keep your LDL as low as possible. That was the mindset. And I know, Troy, you've had conversations with cardiologists, Dr. Allo, for example, and there's other cardiologists and lipidologists on X now that repeatedly say this same stuff, that if we get your LDL to 30, you can't have, literally say this, that you can't have an event, right? And it's just complete bullshit.
Yeah. You raise your hand and go, look, I did it. Trust me, it can be done.
Yeah. Yeah. So, all they had to do is look at my HDL and say, maybe this is metabolic, because that's what we see now all the time. Right. And the other issue the other thing that just makes me so angry, Tro, you're speaking of anger, is this continued, despite years of data and loads of science, this continued glucose centricity. It drives me crazy. The A1C is, yes, it's valuable. Glucose toxicity is a real thing. But we are missing so many people. And this is the biggest confounder in all of the cardiovascular literature, right? The big issue with it is, the issue is, right, there can be a couple of things that can be true all at once. ApoB particles, LDL particles can be part of the causal pathway of atherosclerosis. And at the same time, we can have some question about whether or not LDL and ApoB are independently causal of atherosclerosis, especially when you almost always have the confounder of insulin resistance and obesity, which both drive atherosclerosis risk and raise your LDL. It's a confounder that is present in all of the literature, because all of the literature involves studying people that are probably insulin resistant, but you're not controlling for it because you don't measure it correctly.
Isn't it mad? Isn't it maddening to you that Dr. Kraft's data was released so long ago, his book was so long ago, and it seems like I mean, when I talk to cardiologists about insulin resistance, they look at me like I'm in a different planet.
Yeah, absolutely. Yeah, and the population of people that I see in my clinic is so interesting to me, because I get a very big mix of people. And I've been collecting data now for a couple of years, and I want to publish it. I haven't done that yet. I'm still collecting it, but one of the things I've been looking at is what do we see in an unselected AF population, atrial fibrillation population, right? And you probably see this as well as I do. You see atrial fibrillation and you see an incredibly wide range of what people look like and what they bring to the table, right? Some people are thin. Some people are obese and are suffering all of the consequences of obesity. They come in and they have dyslipidemia that is obesity mediated and insulin resistance mediated. They have hypertension, they have sleep apnea. And then you have other people that are lean looking and don't have hypertension and don't have this and that. And then you wonder what's the common thread here? Well, if you simply test everybody, which I've been doing with a HOMA IR, it may not be the best, absolute best insulin resistance test in the world, but it's certainly better than the A1C. We are at over 95% insulin resistance diagnosis in an unselected AF population. So atrial fibrillation is really just, in my mind, it's really just a diagnosis of insulin resistance, right? And you have a couple of interesting things regarding insulin resistance and obesity. When you get ectopic cardiovascular tissue, there's a direct effect. You have adipose tissue directly infiltrating the myocardium. You have cytokine damage, so inflammation, reactive oxygen species. You have alteration in autonomic nervous system signaling, which is important as well for atrial fibrillation. And then you have the indirect issues of all the impact of insulin resistance at the level of different tissues. And one of the problems with insulin resistance is that it associates with hypervolemia. It affects nitric oxide. So hyperinsulinemia downregulates the insulin transduction signaling system, and the nitric oxide is part of the same system. So your IRS1, your PI3K, your kinase, your AKT, your PPAR gamma, that whole system is also nitric oxide, right? And it's one of the big issues from a cardiovascular risk standpoint overall, but also atrial fibrillation because it affects the hemodynamics. Now you've got hypertension, you've got hypervolemia, and those things affect the heart as well. So it's this vicious circle and this double whammy risk factor. It's really sort of a quadruple whammy risk factor that I don't think people are grasping. And you've got to shrink. Number one, you've got to recognize that all of these diseases likely have overfatness, and the issue of overfatness in ectopic adipose tissue, insulin resistance effects, and the solution has to be based on that pathophysiology. And it's not taking pills. Pills are not going to fix, the Ralph DeFranzo has the ominous octet of insulin resistance and diabetes, right? 8 areas in the body of pathophysiology of insulin resistance. How can a pill, reverse 8 areas of dysfunction? It's not in our lifetime anyway. Even the GLP-1s don't. Not all 8 areas, and there's probably more than 8 areas, right? So we've got to come up with solutions that shrink our fat cells. And the first thing that you've got to do is number one, you've got to know what your insulin is, and then you've got to do something to get it down. And the first thing and the biggest thing is nutrition, right? Once you fix that, then you can deal with energy restriction. But you've got to eat in a way that gets your insulin down.
I've seen data for AFib, I've seen data for AFib showing the impact of weight loss, improving magnesium status, which basically means your insulin's low, not having sleep apnea, which is, as you said, due to excess adiposity. I would contend that if you're like early in the sort of, early in that AFib diagnosis and you have very infrequent low AFib burden, that this can be completely reversed. Is that, am I crazy to think that,
No, you are 100% correct, actually. And they've shown this. They've shown this. They've shown that you see, if you do biopsies, you see the fatty infiltration, right? So if you lose your visceral adiposity, that's going to resolve. But as a consequence of both the inflammatory and fibrosis, downstream fibrosis, and the physical disruption, you see electrophysiologic change. So you see conduction changes, and those all reverse when you fix the adiposity. So both the fibrosis actually reverses, the adiposity leaves that tissue, and the conduction abnormality, when you measure conduction velocities through that tissue, because you want it to basically be, you want it to be homogeneous, you want it to be uniform, right? The conduction proceeding cell to cell, region to region, you ideally you want that to be very uniform. When you get disruption in conduction velocities, you start getting conduction wave breaks, and that then promotes something called re-entry. So the electrical impulse breaks, and then you get the potential that you get a circuit that may re-enter, and that's really what atrial fibrillation is. And so homogeneous conduction is at the cellular level is the key. And you disrupt that completely when you start getting infiltration, whether it be adipose cells, fibrotic tissue, cellular debris, what have you. And so adipose tissue on your heart is not your friend. And it really comes down to just leanness, right? We ultimately need to be leaner. Yeah, they've shown this in animal studies. So you're absolutely spot on. It's reversible, especially in the earlier stages. Obviously, there's a gradient where you might reach a chronicity or a burden of fibrotic disease in the atrial tissue that may not eventually then be reversible. But these are patients where you're seeing, severe left atrial enlargement, and if you go in and you try to do an ablation, what you would see if you record all the electrical activity in the endocardium on the inside of the atrium, you'd see lower amplitude signals, very fractionated signals, so signals that have long duration, again, which just means that physical disruption and the electrical impulse has to kind of do this to meander through instead of rapidly through.
I think, I wonder what it's like to be part of your group now, because I'd imagine you're very evangelized to tackle sort of chronic disease in a holistic way. I'm curious, how does that resonate with your colleagues? How does that resonate with sort of the mainstream in the area that you're in?
I think it's mostly positive. I've only been in the Intermountain system now for 2 years, so and we have employed physicians, and we have affiliate groups that are part of the cardiovascular division. I'm actually chair of the cardiovascular division for the hospital here that I work at. So I have an influence. I run grand rounds. I can kind of control some of the topics, and I actually gave a grand rounds for our cardiology section, and did a lot of, and had a discussion about a lot of this, and some of it was received well, some of it not so well. It's such a dogma, and there's a lot of entrenched beliefs, and so, I think people are collegial, and they're nice, and they listen, and some of them even refer patients to me. As an electrophysiologist, they refer patients to me for metabolic treatment. So I think that that I would say that overall it's been favorable, much more favorable than previous employment models that I was in. But it's a battle. There are just deeply held, entrenched beliefs and dogma that are hard to pick away at.
It may be a hard question because you changed systems, but are you seeing a huge uptick in atrial fibrillation in young people in the last couple of years?
Oh yeah, absolutely, absolutely.
Yeah, every cardiologist I talk to is saying the same thing that there's, and I'm seeing it. Young, healthy people. I have 8 doctor friends who all develop atrial fibrillation, myocarditis, pericarditis in the last 2 years. And it's just when you see, you think this is, and they're the athletic guys. They're not the guys who are sitting around doing nothing.
Yeah. I mean, it's by far my most common visit is for atrial fibrillation. Well over 50% of my patient visits are for atrial fibrillation. And it just goes along with all the other epidemics that we're seeing, right? And it makes sense. Obesity and diabetes epidemics, it just goes right along with that. And I think the same thing with coronary disease. We just are, we're not seeing the tip of the iceberg, in my opinion, because I also see a lot of AFib where, sometimes the disease process, the root cause is there, but it may manifest differently, right? And this is one of the problems I think in all of medicine is that we tend to view things as in these little silos, right? And we don't recognize that the AFib patient is an insulin resistant patient, the coronary disease patient. They're just manifesting first somewhere. The cancer patient's a metabolic patient. The cardiac patient, the coronary patient's a metabolic patient. The AFib patient's a metabolic patient. And so sometimes I see patients who just manifest first with AFib. But when you go looking, you see dyslipidemia that is metabolic. When you measure their insulin, as I said, over 95%, we see very elevated insulin. And then if you say, look, I'm concerned about your overall cardiovascular risk, not just your atrial fibrillation, and you explain the reasons why, and they agree to do like a CAC scan or a CT angio or something, you see disease. It's universal. So it's there.
Well,
It's there because they all have the root cause for all of those things.
Well, the thing that takes me back about your story too, and I may have gotten the years wrong, but it sounds like you were on a ketogenic diet for like 6 years before your prostate cancer diagnosis. Did I understand that right?
Yeah, that's
So
correct.
you were presumably metabolically way healthier than you were prior to that, but you still develop a
Yeah,
can, and that's a scary thing when you
right.
say, okay, I'm doing everything I can metabolically and you develop something.
But when you think about it, with prostate cancer specifically, it makes sense, right? Because I probably had cancer for probably 5+ years.
Hmm.
It's generally a relatively slow growing cancer.
Yeah.
Most of them, and I could have because I had a little bit of fluctuation in my PSA. One year would be 1.5, and then it was 2.7, and then it was 1.7, and then finally it reached 3. Right, and that's over a 4-year period of time. There was a little bit of an up and down there, and I bet I had cancer, and I bet my diet was probably helping to
Keep it at bay.
not have
Yeah.
keep it at bay a little bit. Yeah,
Yeah.
absolutely.
And then after that, after you got the diagnosis, how did you change your ketogenic diet? You went on a higher fat ketogenic diet, and you looking at the GKI and glucose ketone index, and then also were you throwing in fasting with Dr. Seyfried's stuff also?
Yeah, I would say that before the cancer diagnosis, I was probably fasting. I was doing some time restricted feeding, but I wasn't great about it. I'm someone who has coffee in the morning and I put coconut milk and almond milk and it's kind of a latte, I guess you will. And so that breaks my fast. And so I tend to eat breakfast around 9 and then and then I have a little bit of a snack around noon, and then my last meal is around 2. And then I don't eat after 2. And it's just my wife and I, my kids are all gone. And so it's easy for the two of us to do that.
Hmm.
Um, my wife has MS, and and she benefits greatly from the same diet. So we support each other in that way. And but I wasn't terribly dogmatic about the time restricted feeding.
Mhm.
Now I am 100%. I don't eat after two. And so I'm in an 8 hour window. I basically eat 2 meals a day, and I have some. I typically will have some raw cauliflower with kind of swipe it across some almond butter as my midday snack. Um, I'm not carnivore, but I would say I'm pretty close. That's probably the mostly
Mhm.
the vegetables that I eat is raw cauliflower and maybe raw broccoli. Um, and but I was before cancer, I was more fixated on protein than I was on fat.
Mhm.
So I did not restrict. I eliminated all grains and seed oils. I did not restrict saturated fat, but I had a pretty good mix. I eat fish almost every day. I have salmon and
Mhm.
sometimes eat sardines. So I have fish every day. I eat lean ground beef mostly. That's grass fed, grass finished. Um, I don't eat chicken. Um, and so I was pretty fixated on protein, eat the fats that come along with my proteins. I do dairy fats and avocados. And that's probably my main sources of fats. But but with the cancer diagnosis, and then so what I think what happens though with ketogenic diets when you're on them for a long time is your weight, your body fat stable. I think it's very hard to run high ketones. I don't know what you've experienced, Tro.
Absolutely correct. Yeah, that's totally true.
Yeah.
Absolutely. I
I
see the
mean,
same thing. The longer you want it, your
yeah.
GKI, yeah, and your
So,
ketones will run, less than one usually after a
yeah,
prolonged time. Yeah.
yeah, it's kind of super interesting what happens. I mean, my ketones now run, and I'm very weight stable at 150. My ketones run about zero point 0.5 to 1. Yeah, zero point 0.5 to 1. I literally had to do a 3 day fast to get my ketone above 3. And obviously I can't do that forever, right? So I'm not as fixated on the GKI as much anymore because
Mhm.
I really believe in the molecular hydrogen and the deuterium depletion as a way to promote mitochondrial health along with all the other things that I'm doing with red light and sunlight exposure and I do blue light blocking when the sun goes down. All those things. I'm really very mitochondrially focused. Um,
Do you
but
do
yeah,
sauna by any chance?
I don't.
Huh.
So
I
you got him,
I I
Brian.
I want to do sauna. Yeah, I want to do cold thermogenesis and sauna, and so I'm in the process of building a home, and I'm going to put a sauna in the new home build. That's my plan. But yeah, I did hyperbaric oxygen as part of this press pulse and also just for post-operative healing. And so I got hooked up with a clinic here in Heber that had that, and they have sauna. And I've thought about implementing that now as well because my cancer is actually sensitive to thermal exposure.
Mhm.
That's one of the sensitivities. Uh, so yeah, I'm going to do that for sure.
No, I'm just
Even
curious because we actually had a guest on years ago, and I remember Tro and I were like, "Oh no, what's he talking about?" But he was talking about having bipolar very severe, went on ketogenic diet. He said the thing that works for him is putting all these snow clothes on in the middle of the summer, and he goes running where no one is, and he says after that, my mood stabilizes for months after that. And then you go,
yeah,
wow. And there was these heat shocks, but now there's studies coming out saying, yeah, it does work.
Yeah, the thermogenic stress,
Yeah,
the
thermogenic
thermogenic.
stress. Yeah. So I was just curious from the nitric oxide and all that release from saunas and and there's a lot of good data out there it's just you don't hear about it though.
yeah. So to get back to your
Huh.
question, though, I tried to lower protein a little bit and raise fat a little bit, and it just didn't move the needle on the ketones, and so I just said, forget it. Um, so I kind of just go back to doing what I do. I was able I was able to get my. I think here's the other thing that was interesting, right? So You talked about stress, which I think is really a big deal because I gain weight. I gain weight so easily, and stress is something that does it. So I gained 10 pounds back around the time that I got the cancer diagnosis. And when I just tweaked the diet a little bit more and implemented more consistent fasting, I brought my weight back to 115, and my ketones rose when I was in that fat loss
Did you
stage,
say
just 10 pounds.
115? Did you say 115?
I'm at 150 and
Oh,
I went up to
50. Okay.
150 and I went up to 160, and I think it was just stress.
Stressful, yeah. Cortisol affected stress. That's why I was curious about what your workouts are like because yeah, I just interviewed Mark Sisson. And it's really been in my brain because he was a high end athlete running ultra marathons and all this stuff. And now he says, look, go for walks. It's better physiologically for you, less atrial fibrillation, less scarring. He goes through the physiology and go, wow, it's pretty interesting. A guy who's run so hard, he said, no, it's just, you might get that adrenaline rush in your brain, but there may be a better way to do it of doing a slow, sustained, zone 1, 2 exercises more so as 80 or 90% of your exercise, then going all out a couple, once a week maybe, and then doing weights, for the metabolic effects of that.
That's what I do now. I walk. I'll occasionally do a 30-minute Peloton ride. Um, when the weather gets warmer, I'll go out on the bike a couple times too, but not long. And then I do resistance workouts probably 2 to 3 times a week, and with some yoga. Um, so that's my kind of workout regimen now, and definitely I think it's healthier than before when I was riding a bike hard for 5 hours.
Well, and you change your lifestyle too, and that you're in a practice where you're not flip over driven, and you can spend more time and you can actually have an impact. So you get benefit from that physically, like Tro and I do too.
Yeah, yeah. I'm in the process of adding on outside of Intermountain, where I do a half a day clinic a week as part of an umbrella entity called Impact Medical here in Heber City, where I give metabolic consultations. Um, so I'm kind of excited to embark on that endeavor as well. Um,
It's gonna bug me and our listeners. Do you ever do any like online consults or anything like that from a
I
metabolic
haven't,
cardiology
I
perspective?
haven't, but I think I'll have the ability to as part of this project with Impact Medical. Um, and so it'll probably be, remote, a lot of remote virtual visits, as well as
Mhm.
some office-based consultations. And I'll do it. I think the plan is to do it half day a week. The problem is I have to broaden my licensure. I'm only licensed in Utah right now.
Mhm.
Uh, so that'll be part of it.
Well, Arizona's right next door to you.
Yeah, there you go.
I'm in Arizona. I know a lot of my patients would love to come
Yeah.
talk to you. And then you talked about the hydrogenated water. A lot of people are talking about alkalinized water. What do you think about that? I don't know. I always think about from a gut microbiome perspective, and it gives me a little pause. I don't know how you two feel about that.
Yeah, I don't know a ton about that specifically. I do know that there's a lot of companies that are trying to popularize hydrogenated water, and selling these little bottles that will hydrogenate water, and there's different ways of doing it, and it does get kind of nuanced, and I think you have to be a little bit careful. I definitely think a generator, if you're going to do it, a generator is the way to go, but there are actually different generators out there. The generator I have does electrolyze the water. Um, but the amount of hydrogenation is way more than you can get from, these cheaper sources, or when you just put hydrogen tablets in a glass of
Hmm.
water. I just don't think you're moving the needle all that much. Um, to me, what's most intriguing about the hydrogen is they saw when they improved hydrogen concentration in the body by giving psyllium or inulin to patients in the press pulse protocol, they had better results. Right. So again, the thinking now is moving towards the idea that this press pulse, this ketogenic and glutamine and hyperbaric oxygen actually all might have an underlying other basis to the benefit, which is hydrogen and deuterium. And hydrogen is just the ultimate antioxidant, right? I mean, I think if you're, I think my mitochondria are really solid right now, but who the heck knows? We still have issues of environmental exposures, plastics and all these things. And when your mitochondria get disturbed and they produce free radicals, reactive oxygen species, normal, but you just don't, and that's what our antioxidant systems are for, is because mitochondria doing their thing produce reactive oxygen species, and that's an important signaling molecule. You just don't want it to be over the top and overburdensome. You don't want to overburden your antioxidant system. And I think this is where it gets really challenging, is how do you know that your antioxidant system is challenged, and what's the best way to enhance that? What's the best way to lower reactive oxygen species generation? There's dietary issues, right? Eating ketogenic, allowing for more fat burning and ketones cycling through your mitochondria is one way. The worst way is a high carbohydrate diet. Because the reason that we're going into, I can go into the weeds here a little bit. The reason is that when you oxidize fat and ketones, you bypass complex 1 of the mitochondria, which is the leakiest, right? So you leak more electrons. You leak more electrons. You form more free radicals when you bypass. If you form less if you can bypass complex 1. Which is basically what you're doing when you're feeding it more fat and ketones.
Yeah, when you're fasting or on a ketogenic diet or a higher fat. And the other question I'd have to ask you to both of these, since I have you both, because I had a patient come in just yesterday that had a new onset of recently diagnosed breast cancer, and she goes, "Yeah, I looked at metabolic health and I found you because you're in San Diego and I'm in San Diego, anyways." I said, "Who recommended like metabolic health?" Said, "Oh, my cardiologist told me to go on a ketogenic diet immediately." I was like, "What? Like seriously?" But what's interesting is they consulted with an oncologist, a nutritionist, and she said super low protein. I was like, I don't know if because they're worried about mTOR. That's their big thing they're concerned about. I'm thinking, yeah, and I would love to pick your brain on that a little bit, just because, I think if you lose muscle mass is the worst thing you could possibly do.
Yeah, I think that's not good advice. Protein is one of the biggest driver. I mean, you know about the protein leverage, right? I mean, it's a great satiety. It's important for lean mass preservation. And I think that there's just tons of science that supports that protein's hugely important, and that we probably on average underconsume protein. And everybody here knows that your animal sources are your most complete and most bioavailable. The mTOR issue, the worst thing for your mTOR is a junk food diet. A high carb diet, high process, ultra processed food is way worse for mTOR than is protein. Totally not concerned about mTOR when it comes to protein.
Awesome.
Yeah. Do you guys?
Wow, we got to cover it, man.
Yeah, this is awesome. This is awesome. I could go on for hours. Gosh, we all have to get back to clinic, I'm sure. I'm sure I do, but I'm curious. One last thing before before we sort of part ways. Because this isn't something they teach doctors, and I'm just curious to hear your own personal account. What is your supplement stack right now? If you had to list out your supplement stack, I know this sounds like a cheap question, but I want to hear every supplement you're taking right now. I'm just curious.
Do you want to know what I would do, what I'd be doing if I didn't have cancer, or after cancer?
Sure. Either, I mean, whatever you're doing with the cancer, whatever you're doing.
Well, if it was just cardiac issue that I was known to have, and what I did when I was a cardiac patient, it was So I took berberine. I would cycle berberine, and that was more because, I knew that insulin resistance was the biggest driver for my atherosclerosis. And there's actually now some interesting data on berberine and plaque regression. And so I took berberine. I took something called CX8, which has 8 different things in it. It has vitamin K2, nattokinase, and I took vitamin D I target 60 to 80, preferably closer to 80 for myself. And then let's see what else. I did supplement. I've been CoQ10. I still take. I started CoQ10 because of the statin issue, but I just continue it. And I take marine omega-3 supplementation. And so I take about 4 grams a day for cardiovascular benefits and inflammatory benefits. There's a little bit of a signal for AFib risk when it comes to marine omega-3s. Some of the data, there's some data that says there isn't, but some data that says there is. I think the last meta-analysis on that I looked at, it was a 25% relative risk increase. I don't think anybody understands what the mechanism is. Doesn't make a lot of sense to me, but that's what we're seeing. That doesn't seem to be an issue with plant-based, but plant-based has to be converted, and the conversion rate's fairly low. Those are the main ones. Now with the cancer, I'm on a every other month alteration based on sensitivities. So I currently take pretty much everything I've already said. Plus, I take vitamin C. I take curcumin. I take something called vacustatin, which is not a cholesterol statin drug. It's an anti-angiogenic supplement. And I take artemisinin. I think that's my current regimen, and every month it's going to change because I've got a lot of sensitivities, which is good. So, hopefully that the changing prevents any kind of sensitivity, any kind of resistance forming in the cancer.
Wow.
And since I get asked the last question, Tro, Doc, how is your mental functioning? How is your perspective of life changed after getting 2 life-threatening diagnoses? Like, do you smell the roses more? Do you slow down a little bit? Do you do something to escape the stress of life, or have you changed any way because of this?
Well, I think I already had done that. I kind of fell into it actually. Intermountain. I fell into the Intermountain job. And so I think that was just fortuitous. But I think my work life stress is much less, and I'm in a better work environment. So work life balance is better, is easier to achieve. I I think my exercise regimen is really solid. I don't find it stressful at all. Stress is a big actual de-stressor for me. It's always been my go-to mental health prescription. But I will tell you the one thing that has made the biggest difference, and this is going back 7 years now, is the diet. 100% the diet. I don't have food noise. I don't have problematic cravings. My mind is just so much calmer eating this way, and I didn't even know it until I switched. And this is even, and I switched, I switched from 6 months of veganism, strict veganism, to this diet, and I could sense the change immediately. For me, I don't know if I'm just someone who's incredibly carb intolerant, or what, or if it was the fat change, One thing I forgot to mention, which I think is hugely important as well, because we kind of talked a little bit about LP little a as this LDL type particle that has an apolipoprotein A. It has additional protein on it that distinguishes it from LDL, and it's felt to be an independent genetic cause of ASCVD. My LP little a, when I changed diet, went from 131 to 37 milligrams per deciliter. They say that your LP little a is not modifiable by lifestyle, and that is just complete and utter noise and nonsense. This is one of the problems in cardiology, right? Because this is the paradox. Saturated fat might raise your LDL-C a little bit, which I think is also problematic because we need to be looking at ApoB more than LDL-C, because a lot of the LDL-C changes can really be very misleading. As I mentioned, mine didn't change very much at all, but directionally where they changed was actually favorable. I went from a type B small dense LDL pattern to a type A, and my ApoB went down. Actually went down. My LDL-C went up a little bit on a higher saturated fat diet, right? And that's what they tell you. Your LDL-C is going to go up. Oh my God, you're going to have a heart attack. My ApoB went down.
And you flip from pattern B to pattern A.
Because I flipped from pattern B, which I had lifelong, to pattern A. My
Wow.
saturated fat lowers your LP little a, or to state it alternatively, a high grain, high carb diet raises your LP little a.
We saw a 15%, when we did a practice-wide audit, we see a 15% change in LP little a, which is consistent with David Ludwig's interventional trial, which showed the same thing.
Yeah, so
I agree
I'm
with
probably
you.
a little bit of an outlier. I think I
No,
agree.
we've
That's what I
seen
see
that.
too.
I've seen that. I've seen, 300s go to 100. I've seen,
Yeah,
nanomolar, like just a different unit. I've seen changes like that. It just shows you not to believe the dogma and to
No.
keep questioning, stay curious. I mean, your story just reminds me to fight the system, be curious, keep learning, surveil, don't trust, don't trust medicine, surveil, right?
yep,
And
absolutely.
make if you're a patient out there listening to this, the medical system failed the three doctors here on this call right now. They failed us spiritually, they failed us physically, and they failed us morally in that we have not lived up to why we probably all went to this field. And so systematically, medicine has failed on every possible level, centralized medicine, I guess we can call it. But and your story just makes me think like, don't like show me my health improving. You need to ask your doctor that. Show me that my health is improving. Prove it to me,
Yeah,
right? Because I don't trust you. And that should be the basis for every conversation in the nation.
yeah.
I'm so triggered by your story. I want to
Yeah,
know.
I keep thinking the same thing, Tro. I'm like thinking like your story flies in the face of everything we've been taught, and you think, oh my goodness, like you're doing the exact opposite and you get healthier. It's just incredible. It's an incredible story. I'm so glad you were here to share it with us.
Yeah, thank you. No, it's a privilege, and I appreciate it, and I agree 100% with all your comments. And Ryan, I just want to say that I think when you adopt a health-centric paradigm instead of a disease-centric paradigm, things change. And I've got a ton of hope. I've
Mhm.
got two of the four horsemen for mortality, and despite that, I actually mentally am in a great position. I've got a ton of hope. I know that I'm going to beat both of these things, and I'm going to live a long, healthy life, and I feel great. I mean, I've actually. It's amazing. I've got heart disease that's pretty significant. I've got cancer, and I actually feel incredibly healthy. And
Yeah.
to me that's just incredibly empowering, and I know of no better way to be. And it all comes down to focusing on the things in the lifestyle that really, really matter and ignoring the noise.
Yeah, I think it's like that's an amen right there. And that's a, I think that's a take home. Like that encapsulates all this is really, and I've been intrigued by people who overcome cancer, and sometimes they go vegan and overcome cancer. They do different things, but the one thing they do is they have hope. They go, I'm going to try this. I'm going to have hope that this works, right? So there's some benefit to that. You call it a placebo effect or whatever you want to, but there's the power of hope. Dr. Unwin's taught us that also. It's like if you have hope that you could be better, or that you could come off insulin, or that you can improve to have something at 52 and you're a cardiologist doing all the right things, and you go, now what? I'm doing everything right, and then you have a disaster happen. So it makes you have to say, well, maybe I'm not doing everything right, and I have to look. So your story is so helpful, and I'm going to recommend this to all my patients to take a listen, because there's so many messages here.
Awesome.
Thanks for coming on.
Yeah.
Yeah.
Thank you guys.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.